Good morning, everyone, and welcome to this joint webinar by the ONCO-CLIDE and DIOPTRA projects on colorectal cancer. So today's webinar theme is Bridging Innovation and Care, Advancing Colorectal Cancer Diagnosis Technologies. My name is Giada Martello, and I'm a Communications and Dissemination Specialist for DIOPTRA. I'll be your host for today's webinar. I'm also here with my colleague, Galileo Disperati, who's running the IT setup and making sure that this webinar flows smoothly, and the colleagues from ONCOSCREEN, Ivana Katz and Eva Kelly, who supported in the organization. So this is the second edition of the ONCOSCREEN and DIOPTRA webinar series. If you missed last year's session, which focused on research and awareness, you can find it on our YouTube channels. As you may know, March is dedicated to raising awareness of colorectal cancer. It's a critical time to highlight the importance of screening and early detection in reducing the incidence and mortality of this disease. The European Cancer Inequalities Registry reports that colorectal cancer is the second leading cause of death in Europe. However, in countries with long-standing screening programs, the incidence of colorectal cancer has decreased significantly. Unfortunately, though, incidence rates have either remained stable or increased in countries without such programs. Screening programs are implemented usually at regional or national level, and differences exist among countries. Socioeconomic inequalities, such as differences in education levels, living in rural versus urban areas, and household income can all affect screening participation. So coordinated action at EU level can definitely help ensure that all citizens have access to cancer care services and reduce the burden of this disease. And both DIOPTRA and ONCOSCREEN projects are working towards reducing screening disparities in Europe, and you'll hear from both projects shortly. Just to finish on a technical note, this webinar will be recorded and you will receive the recording link soon after the webinar itself. And last but not least, we also have a dedicated Q&A section, so you can write your questions or doubts or curiosities in the box, and we will uncover them in the end. So now I'd like to introduce you to our first speaker from DIOPTRA's coordination team. Stavros Miloulis is an electrical and computer engineer with a focus on biomedical informatics. As a core member of DIOPTRA's coordinating team, he supervises requirements and project implementation workflow. He will provide to you an overview of the DIOPTRA project. So Stavros, whenever you're ready, the floor is yours.
Thank you very much, Giada. Good morning to everyone from me. Trust you can see my screen, we're okay. Thank you for the introduction as well. I'm Stavros Miloulis. I'm a member of the Institute of Communication and Computer Systems, ICCS, part of the National Technical University of Athens. And I'm going to present you in brief some details on the DIOPTRA project and how it all ties in our today's webinar for bridging innovation and care. First, some administrative information on the project. We're trying to combat the issue of colorectal cancer. We're trying to tackle prevention and screening using novel protein biomarkers. I'm going to describe later on some details. We began working in the beginning of 2023 and we'll be running for 4 years. Our budget over $13 million, and we are the 13 million euros. I'm sorry, and we are the coordinating team, basically our laboratory, the biomedical engineering laboratory. What the project does, basically, as I mentioned, we're trying to introduce a minimally invasive screening solution for CRC, utilizing both protein biomarkers derived via the blood and risk factors. Basically, we're trying to tackle the problems that Giada mentioned, where edge thresholds are going down, incidence is rising, and right now the primary means is colonoscopy. Many people are not getting colonoscopies, they don't really come to hospitals for the process, so we're trying to find an alternative solution. What we're implementing is we're trying to analyze colonoscopy samples and blood samples from people visiting the hospitals to identify proteins that can be detected in blood samples, and we're combining these biomarkers with some risk factors coming from clinical data in order to provide a holistic and thorough model assessing CRC risk on a personalized level. And of course, we're trying to implement artificial intelligence methodology in order to assess the prognostic power of each factor within our screening model. We're trying to analyze 4 diagnostic groups based on the screening. Of course, we're trying to distinguish the healthy people, those that do not need colonoscopy, the CRC cases, and we're trying to focus in the between groups. Since the project target screening, we need to identify those at higher risk or lower risk. So we're trying to identify cases of non-advanced or advanced adenomas in order to assist the clinicians to propose the adequate measures to prevent precancerous cases as well. And as my colleague Ioannis Vezakis will also present you later, we're also trying to introduce a mobile lab to increase public awareness, to introduce behavior-based risk assessment, and to promote the lifestyle medicine that is so crucial with regard to conditions such as the CRC. Now, what is the impact we're trying to bring in the clinical standard right now? What's happening? We have the general population, the majority receives no screening at all. Participation rates are very disappointingly low, I would say. Some of the population receives colonoscopy, and we identify some CRC cases. Within the DIOPTRA, we're trying to get people into screening using the mobile app to get them to know details on CRC, prevention, screening methods, etc. To provide our tool as a first-line screening methodology based on the biomarkers, based on risk factors, and on the next level, we're trying to assess an extended population. Those who are okay, those who do not need colonoscopy are tested. They don't need to be, to have a highly invasive process. And those who truly need the colonoscopy will be guided to the hospitals to get the process, to get the definitive diagnosis. In this work, of course, we're not alone. No one is alone in this research field. We have 28 partners right now working on the project from multiple countries, as you can see, including 9 clinics in 8 different countries. One of them is the Attikon hospital, and Professor Ioannis Papanikolaou is a colleague I will present today later on. Involved disciplines, as you can see, includes clinical, oncology, gastroenterology, of course, the technical to include the data analytics, the data collection infrastructure to connect all the hospitals that are part of our studies, the biological, of course, the legal with regard to the compliance of the clinical studies to ethical legal standards, business sector, of course, to create a solution that can be deployed in clinical settings, and marketing to enhance our outreach of our project, of our outcomes. That's why Giada is here as well. Our clinical studies now towards a solution include, of course, the biomarker discovery study to actually establish the proteins that can be used for CRC screening. This includes an initial study utilizing, as I mentioned, colonoscopy samples and blood samples in order to define proteins that are present in both samples and can be used, to detect CRC and risk with using just the standard blood work without the need for colonoscopy. Our clinical studies, of course, extend to data from electronic health records in order to incorporate risk factors as well. We have a retrospective study using past records from our collaborating hospitals, health records from healthy individuals, from CRC patients, etc. And all hospitals are connected within a centralized DIOPTRA database. They're providing their data to us. Of course, the anonymized data will protect the privacy of everyone participating in the study in order to conduct our analysis. And the final part is, of course, our prospective study, where we're trying to collect more data based on our previous studies on the project, what we need, and we're trying to validate our solutions to see if our biomarkers will truly work, will truly have diagnostic value, if the risk factors actually hold as a means to enhance the CRC screening and prevention. My colleagues later on will provide you more details on technical and clinical parts. Now just a brief summary of where we stand right now. We've developed the system connecting all hospitals. We have done with the part of acquiring the retrospective data, the available electronic health records from all hospitals. We're done with the biomarker discovery data collection. We have the paired colonoscopy and blood samples to have the initial idea on the biomarkers that we're going to target. We have some results on that as well. We have the first version of the mobile application to be deployed within our clinical studies. And we have prepared the framework to actually conduct the analytics on the data to find the significant features that can be exploited for CRC screening. Right now, with the process of organizing the whole data sets, we're supporting, of course, the hospitals with the use of the system, with the sensor system of DIOPTRA. And we've also started with our prospective study, collecting new data from individuals, from citizens visiting all collaborating hospitals, seeking screening services. We're recruiting them into the DIOPTRA study to get blood samples and other data as well. And from here on, we will proceed with developing our actual solution for testing if it's actually useful for CRC screening. Hopefully, yes. We're trying to develop a biomarker assay, a test, the actual test that can be used with the blood samples for screening purposes. We're going to implement to use the mobile application for a behavioral change study. You'll hear more details on that later on. And hopefully, if everything goes well, we have promising results on the risk factors or the biomarkers. We can actually make a difference in CRC screening to assist the clinicians, to assist the population, and produce new guidelines that hopefully can be implemented on the EU level. Of course, we're a research project, but hopefully we can actually contribute to making a difference. That's it from my part. Thank you very much.
Thank you, Stavros, for the very insightful presentation and overview of DIOPTRA. I definitely think that the project can contribute to making a difference. Next, we are going to dive deep into the ONCO-SCREEN project. And so we are going to hear from its coordinator, Ioannis Fotopoulos, Research and Innovation Manager at EXUS. So Ioannis, whenever you're ready, the floor is yours.
Thank you, and thank you for this very nice initiative. I believe that we should promote the synergies across projects, so it's always nice when we can hear two different projects talking about what they can do in regards to CRC. From our side, I will try to make it a little bit more light for you, so I won't share any presentation, but I will say some key facts about us. So we are having, similarly to DIOPTRA, 11 different tools that try to support the various different aspects of the CRC screening. We have 4 diagnostic devices. One is working on volatile organic compounds, one is working with human CRISPRs, one with circulating tumor cells, and one with NMR technologies. Beyond that, we have a mobile application for the end users, but also a decision support system for clinicians and for policymakers, along with 2 training tools for the support of AI and in regards to AI and the supporting of colonoscopies, but also in tissue images. I would say, along with a risk stratification, that tool that we're going to see right after. Similarly, with DIOPTRA, we are somewhere in the middle of our project and also in the phase of the trial of our prospective trial. So we are testing the tools. We have early results. Some tools are promising, some others we are still optimizing before entering the second phase, let's say, of the clinical trial, where we are going to measure at in a large scale how these tools are performing. Lots of nice things are happening up to now in the project. So we have living labs, we have identification of the barriers of people with screening, other factors, risk factors that have been identified from bibliography, and we are utilizing over the tools, living labs, hackathons, and of course, nice cluster activities like this one that we see today. Of course, all of those are not, let's say, without challenges, and especially today we asked, let's say, somehow to show some AI tools, and always the challenges for AI tools is to find data, and data is always a hard thing to find, especially in the healthcare world, and this can happen because, let's say, the management board of a hospital don't want to give data, or then if they want, the IT department has an issue. If not the IT department, then maybe the legal department has an issue, and then of course it needs to pass through an ethics committee for approval. But things are more or less the same with cancer registries. There are, in some cases, there is too much bureaucracy, and data eventually are not so much open, or in various countries we are not measuring many things. So if you want to have a large-scale analysis on different factors, is always challenging. Of course, as projects, we shouldn't have an excuse, but I believe that we need to discuss about such things, to open this closed box and eventually break silos, and say this and calling everybody for your position, either a big one or a small one, that we need to fight about this. We need to fight about having more data. This is what patients want. Patients want solutions, so we need to provide for them the solutions, and in order to do that with new technologies, we need the maximum available amount of data. As said, tools need to adapt, and this is what is happening. So this is what we did as well. We adapted a little bit our methodologies in order to be more dynamic, with more human-in-the-loop approach, like the ones that Pedro from our side is going to present right after. Before giving the floor, I would like to remind everyone why we are here. We are here because we want to follow and serve an honorable cause about saving lives of patients. Okay, even though our projects are research projects, which means that we are not ready yet, we are still examining our solutions, and we have to make clear expectations with the citizens and patients. They should know that what we present to them is something experimental. It's not for now, it is for the future. So we should always making clear to them that their participation in the trial, their participation with the feedback is for a good cause, and at the same time, what we all do, and despite the challenges that we have, we need to overcome them. We need to find new solutions, because, and we are doing this because we want eventually in the future, through our research, through our projects, our solutions, we want to save lives in order to reduce this burden for the European citizens, for the European families that they face the same problem, but also to reveal those barriers, reveal those inequalities that we have among countries and between countries, for our citizens, moving towards more equal and more participative care for everybody. Thank you.
Thank you, Ioannis, for your insights, and specifically for disclosing what the challenges of your project are, and also of our project, as you rightly mentioned, the research and the experimental components. So I definitely think that this can put our projects into a wider perspective for the audience who is listening. So thank you. And to continue with your team, now I'm going to give the floor to Pedro Lopez. So Pedro is a machine learning engineer in EXUS AI Labs, and he has extensive experience in European projects across various domains, from medical, industrial, and mobility. Pedro will introduce to us the ONCO-RISTE tool for colorectal cancer diagnosis. So whenever you're ready, Pedro, the floor is yours.
Thank you very much. Let me share the presentation. Can you see it? Yeah. So again, thank you for the introduction. As I am Pedro Lopez, I am a machine learning engineer in EXUS AI Labs. I am one of the developers of ONCO-RISTE tool. And I am going to present to you what is ONCO-RISTE tool. So it is a risk stratification tool based on expert knowledge and fuzzy logic that will automatically identify dependencies and correlations among variety of features concerning the clustering of citizens and patients into their respective risk level. This risk level could go from very low to very high, and it is calculated using empirical rules and the data coming from the user. This data includes general factors such as age or biological sex, as well as other factors related with the behavior of the user, nutrition, and test and clinical history. So this is the whole workflow of the tool. The data is collected through the mobile apps from the project, wearables, and also from information given by the clinicians and lab technicians using the different dashboards of the project. All this information goes to the stratification engine, and here what we designed was a methodology where we give the tool to the expert, and they have full freedom to decide which factor shall participate in the risk stratification, what are the default values or to alter them, in a full dynamic process, considering that risk factors are changing all the time. Clinician can add or remove factors, and the system will automatically generate membership functions for them to take them into consideration in future risk calculations. In this way, we increase the overall trustworthiness of the system in regards to stratification engine without the clinician to question the origin of the calculations and the factor while they are taking clinical intervention decisions after receiving the risk calculated. This risk is also provided to the user once it is confirmed by the clinician. Here we have an example of the tool. When the info is collected, the stratification engine compares that information with the risk factors and their impact stored in the rules based by the clinicians and calculate the risk. When the risk is accepted by the expert, it is sent to the user to know next steps to follow. All these actions involving the clinicians are done using ONCO-CLIDE tools, which my colleague Gerasimos is going to show shortly. Thank you very much for your time.
Thank you, Pedro, for the informative presentation and especially for introducing us to a practical example, which always helps when IT is involved. So now then we're going to let Gerasimos Tzivras, software engineer from Konnekt-able Technologies, on behalf of Dionysis Polyzos, who couldn't join, to provide an overview of ONCO-CLIDE. So whenever you're ready, Gerasimos, you can go ahead.
Hello everyone, I'm Dionysis Polyzos from Konnekt-able Technologies, and I'm here to talk to you about ONCO-CLIDE. Moving forward from the risk estimation provided by ONCO-RISTE, the next logical step for high-risk individuals who have started exhibiting symptoms is of course the diagnostic process. This is where ONCO-CLIDE comes in, a clinical decision support system designed to seamlessly integrate into the diagnostic workflow. The goal of ONCO-CLIDE is to increase diagnostic accuracy and reduce the time of diagnosis by consolidating all relevant medical information and utilizing machine learning to provide actionable diagnostic suggestions. To achieve this, ONCO-CLIDE incorporates components of an electronic health record system compliant with the FEBGH standard and integrates both traditional and novel non-invasive early diagnostic methods currently being developed within the ONCO-SCREEN project, including ONCO-VOT, which is a breath biopsy-based screening method using exhaled volatile organic compound biomarkers, ONCO-NMR, which is a CRC screening method via urine and blood NMR metabolomics, ONCO-CTC, which is a CRC screening based on circulating tumor cells, and ONCO-CRISPR, which is a CRC screening method leveraging CRISPR-Cas9 biomarkers. Now, regarding the key interfaces of ONCO-CLIDE, we have identified 4 main interfaces essential for the tool's functionality. The first is the user management interface for the clinic's IT personnel to handle system access, account creation, etc. You can see an example image of this interface on the right side of the screen. The second is the patient and case management interface that provides a way to insert new patient and assign them into cases, of course, into the system and into the overall ONCOSCREEN project. An example image of this can be seen on the left side of the screen. The third is the lab input interface that can be used by lab technicians and supports the upload and ingestion of diagnostic test results, including ONCO-CTC and ONCO-NMR, with the flexibility to incorporate additional tests in the future. You can see an example of this interface underneath you. Now, the fourth and most important interface is the doctor's interface, of course. It features a case management system to centralize patient information. It integrates a suggestion system to provide guided recommendation for the diagnostic process. Now, you can see an example image of this on the right side of the screen. In this example image, you can see also the widget for ONCO-RISTE that is used to both visualize the outputs of the tool and the risk factors considered, while also being able to be used interactively by the doctor to select different weight values and rules and factors for the overall risk calculation. At the end of this presentation, we will have a quick live demo with one of my colleagues. Now, the suggestion system. The ONCO-CLIDE suggestion system consists of two complementary subsystems: an empirical system based on medical best practices and expert-defined rules. It includes clinician-defined rules that can be edited on both an organization and clinician level. For example, you can flag a patient for a fit test if they fulfill certain symptoms or are high risk. You can see an example image of this interface on the right side of the screen and how this rule selection currently is being made. We are working with the partners from ONCO-RISTE to update them with to use this interface for the tool as well. Now, regarding the machine learning, the second subsystem, it's the machine learning system. It leverages real-world patient data to provide diagnostic recommendations. Though the AI systems interface is still under development, we can showcase its inputs, outputs, and overall functionality. The system relies on 7 main input categories: symptoms, early diagnostics, endoscopy findings, imaging data, laboratory tests, patient demographics, and pathology data. As diagnostic results gradually become available over time, the system dynamically updates its recommendation adapting to the latest findings. These input data are structured as seen in these example images and follow a predefined form. The clinicians can select to either agree, disagree, or suggest a different recommendation, therefore slowly refining the recommendations over time with the availability of new patients and inputs. Now, regarding the outputs of the system, some of the possible diagnostic suggestions include laboratory recommendations, imaging recommendations, endoscopy recommendations, pathology recommendations, and referrals. A more detailed view of the current possible outputs can be seen in the provided image. Of course, the number of outputs and types can be extended relatively easily. These are just suggestions, and the doctors always decide on the next step based on their experience and expertise. Thank you for your attention. Now, regarding the next steps, they include the complete integration of all ONCOSCREEN components and the refinement of the interface and the machine learning suggestion system. Now, I will hand it over to my colleague Gerasimos, who will guide you through a quick live demo of the current interface.
So, even if he's not here, I'd like to thank my colleague Dionysis for his presentation. And with that said, I'm starting with a very quick live demo of the ONCO-SCREEN platform. We're going to be logging in as a doctor. Okay, so at first we can see the home page for the doctor, and there a doctor can see his notifications and an overview of all the cases that he or she is responsible for. Now, there is also a dedicated cases page where all of the cases can again be seen, but there are also search and filtering options. And we can click on those cases. We can view them in more detail. And for example, in the main case view, at the top, there are suggestions based on both systems. And there is also different submenus that are organized in 4 separate categories based on if they're the early diagnostics, on whether they're clinical tests, on whether they are reports based on the clinical diagnostics, and the final category that displays the eventual staging when the diagnostic process is complete. So the early diagnostics tabs can be seen here. It is the one with the ONCO-RISTE widget as described before. We can see a bit of the functionality here in a very quick view. There are also the clinical tests that we can see in this page, and next are the diagnostic reports, which also have built-in viewers for different data formats that support PDFs, images, and also medical formats like DICOM. And finally, we can take a look at the rule system that we have, which includes a list of created rules for the clinician. And we can create new rules through this interface here based on the requirements that we have, and we can also select a new rule from the already existing ones. And if we do so, we can view more details about its parameters. We can choose the option to edit it, and we can also see the cases for which this rule is active. Thank you all for your attention.
Thank you, Gerasimos, for this presentation, and also for adding some more practical elements. I think especially the demo is a good example of your project in action. So thank you for that. Right, now proceeding with DIOPTRA, we have a very nice comeback. We have now Professor Ioannis Papanikolaou. So he is Professor of Internal Medicine, Gastroenterology at Attikon University General Hospital in Greece. He's the clinical manager of the Attikon in the DIOPTRA clinical study and one of the project's leading experts overall. He guides protocol creation and implementation, and he will guide us through innovations in screening. So we are definitely very excited to have your point of view here. So whenever you're ready, the floor is yours.
Thank you, Jada. Thank you very much for your kind words and for your patience with me during the process of preparing this webinar, and also especially for the very polite invitation. It's always a good opportunity for clinicians to come and contact to the wider public. So thank you very much for all these reasons. The topic for today is innovations in screening, the role of biomarkers in colonoscopy in identifying precancerous lesions. And oops. Okay, so I have no relevant disclosures, I'd like to say. A few things for the epidemiology of colorectal cancer. It's the third most often diagnosed cancer among humans. It's the second leading cause of cancer-related death in adults in the US. And just to stratify this, we're expecting about 4% of the US population to die from it, which means a very pretty big number, I would say, 53,000 people expected to die from colorectal cancer in this year in the States. So what can we do about this? Earlier detection seems to affect overall survival. There have been various studies that show that the 5-year survival is 91% if the disease is localized, and only 14 if the disease is a metastatic one, which means that the earlier that we diagnose it, that's the better it is for the patient and his outcomes. So going back to our teacher, Hippocrates from Kos, the first doctor recorded in history, he said, "Kallio prolamphanin para therapevin." It's better to prevent than to cure. And in this way of thinking, we have CRC prevention can be analyzed in primary prevention, which means amendment of environmental factors that are linked to the presence of CRC. And this can be either by food or exercise, etc. Secondary prevention, which is implementation of screening measures in the population or in high risk groups to find the colorectal cancer before it becomes actually cancer in precancerous stages, or at least to find it in very early stages. And this is what we actually do as gastroenterologists by performing colonoscopy. And then also there is another aspect that we are also involved in. It's follow-up to avoid recurrence of cancer after its therapy, which is also very significant because cancer can recur even after it's resected. So the role of endoscopy is based on these few points that I will highlight right now. The majority of colorectal cancer is sporadic, and it's due to malignant transformation of a benign polyp. What we usually say using the term, what we mean using the term polyp is adenomatous polyps, that is precursors of colorectal cancer. And it has been shown by studies from molecular biology that in order to go from an adenoma, as we see here in the slide down in the left, to colorectal carcinoma, this needs about 10 years. So it would be logical if we could screen all the population theoretically and take out the polyps, the precancerous polyps, before they turn into cancer, then this would be very nice and it would reduce the incidence of colorectal cancer, logically. So this has been shown, first of all, in this huge study, the National Polyp Study in 1993 already, that resection of adenomatic polyps can reduce CRC by 76 to 90%. So the majority of the population belongs to the average risk. This is 70% of the population, but there are also high-risk people that are the 30% of the population. And this category includes familial CRC, some polyposis syndromes, and also IBD, inflammatory bowel disease, that is Crohn's disease and ulcerative colitis. So for these people, for these individuals, we have our screening programs, and you can see in the left down a colonoscope on the table. We use this instrument, this tube, to insert it into the patient's lower GI tract and to find polyps like the ones you see in the top right, at the stage where you can resect them before they turn into cancer, which is on the top, on the low right figure in the image. So the methods that we use for screening is endoscopy, basically, either sigmoidoscopy, which is a short colonoscopy, or colonoscopy, a complete colonoscopy, a complete visualization of the whole large intestine. Why do we do sigmoidoscopy when we can do colonoscopy? Because it's easier and it doesn't need preparation, and it's easier to persuade people to do it. But actually, colonoscopy is the gold standard. Then there are stool tests where we detect blood actually in the stool, which is indicative of the presence of advanced adenomas or adenomas, and of course colorectal cancer. And here is the space that we have in order to improve this by finding biomarkers that are sensitive for colorectal cancer. And also there are some imaging tests which are pending because using CT, computer tomography, and magnetic resonance imaging, this is also a future goal. It hasn't gone very far, but there's still hope for some progress in this field. So colonoscopy, as you can see here, is very sensitive and very specific for colorectal cancer, and it's a pretty safe test, as you can see here. There are some issues which include its acceptance and its costs. So what we offer through colorectal cancer screening by colonoscopy to the average risk population is to start at 50 years and to perform colonoscopy every 10 years if there are no findings. If there are findings, then you go into other groups where you have to repeat the colonoscopy sooner. And if you're in a high-risk group, then this screening starts at 40. Now, what's the situation in Europe? There are data that show that throughout 32 European countries that the colorectal cancer screening is not at the same point in every European country. There are well-organized programs in other European countries. There are other countries that have no program or are opportunistic, which means that everyone can do it if they feel like it, but not sponsored by the state. And the problem is the participation. You see, it was recently shown that the participation in colorectal cancer screening by colonoscopy varies from 1 to 73%, with 73 in high developed countries like the Netherlands, but very low in other countries where this is not the population is not so keen to participate. Here you see, however, this is very important because as much as people participate in screening strategies, then the cancers that are prevented increase. This is a small circle to show that my country here in Greece, which was in gray, this year started participating in a screening program. And so let's focus a little bit on colonoscopy. Colonoscopy seems to be a perfect tool to find the polyps, as I described it, but it sees that it isn't so perfect as we really thought at the beginning, and that there is opportunity to miss some polyps. So why should I do a colorectal test that is not so pleasant by inserting a tube in my lower GI tract when there is the possibility that I also would miss a colorectal cancer? And also, as other studies have shown, it might be an unpleasant experience due to air insufflation in the large intestine, etc. It is very important, actually, because as you can see here from data, if one does just the short test, the sigmoidoscopy, then we can have a reduce of CRC prevalence by 23% and a reduce in CRC mortality by 31%. So it's very important to have this. And so in order to improve the colonoscopy, we have some metrics. ADR is one of the most important. How many percent, how much percent in my 10 colonoscopies, in how many of them do I actually find adenomatous polyps? I'm supposed to find at least 2.5. So, and as higher as my ADR is, my adenoma detection rate, then the colorectal cancer incidence decreases in my population of patients that I have. So I have a 3% decreased risk of colorectal cancer in my patients if I increase my ADR by 1%. Very important. And why is it imperfect, the colonoscopy? Because there are some technical limitations and there is some ineffective application of technology that we are in the process of improving as a gastroenterological and endoscopy society community. By various techniques. Here are some studies that I have participated in. One was the NBI study that you see here in the right. It showed that applying this technology improves adenoma detection. Here is the FEBGH, which is a new colonoscope that had 3 cameras instead of 1 that improved colorectal polyp detection. And also there are more simple ways to do it by using water, changing of the position of patients, etc., etc. All of this is very important, seeing the polyp, but also effectively resecting it is also very important. Here you see this image where we find the polyp, we use a snare to catch it, to grab it, and then we cut it off and we take it out to send it for biopsy. So the problem, though, as stressed in colonoscopy, is that although it seems nice and it is improving and it gives a solution and it offers resection of the precancerous lesions, not as many people want to do it. As you see here, Captain Kirk certainly didn't want to participate. So another tool that we have used is rectal blood in the stool. These tests seem very reasonable that they can help. Studies have shown that they're not so effective as we would like them to be. They are effective for cancers that are already there, they are sensitive, but not so sensitive for advanced adenomas at the stage where we can do something to prevent the cancer, and certainly not so sensitive for non-advanced adenomas. Also, in a study that we performed in my unit, we showed here that also the uptake, the willingness of the potential patients to do it wasn't so high. People didn't like the test because of its peculiar nature, including defecation and doing the test in the stool. So as you can see here, this means that there is more room for improvement and to find even better non-invasive screening tests, actually tests that are performed in the blood. As you can see here in the right, we have a table showing sensitivities and specificities for these kinds of tests. But as you see, they are not so sensitive, not sensitive enough to use for population screening. Last year, we had an improvement here. It was published in the top medical journal, the New England Journal of Medicine, which showed a new test that was now commercially available in the US. But still, as you can see, the numbers here at the bottom of the slide, they're pretty low. Not so much for already colorectal cancer, but definitely pretty low for advanced adenomas. And this is our aim. So what do we do in DIOPTRA? Our thought and our rationale, as Stavros Miloulis previously said, is to use retrospective data from patients' files, to use prospective data from colonoscopy and patients that are coming to our hospitals for screening and through colonoscopies, and to use them in order to find biomarkers that are sensitive, more sensitive than the performance of the up to now existing biomarkers, which have a low performance, as we saw in the previous slides. So this is a graph that shows that we use liquid and tissue samples, data, demographic data. All this is thrown in the bucket that is used by AI and also our laboratory. And then we want to find a risk factor analysis and to find biomarkers that are sensitive enough in order for them to be applicable, and then to propagate to the population, go have a blood test, and then please go for colorectal, for colonoscopy or whatever in the future. So this is the first test that was done in our department in the trying to identify these biomarkers. And this is the consortium. As you can see, our group here consists of 15 European countries, 28 partners, and 9 clinics in 8 countries, 2 actually in Greece. And here is our where we take our data from. And this is actually a graph showing that we are ambitious to find these sensitive biomarkers, because this is what is unique in our project, is that our lab will search 4,000 proteinic targets in order to refine just 2 or 3 at the end, and try to find which one of these are better and more sensitive for colorectal cancer, and especially for advanced adenoma. As you can see here, here's our group once again, and the Greek teams. What we have done now in the discovery clinical study is we have gathered patients. We have taken blood samples and tissue samples from these patients. You see here we have 60 cases of colorectal cancer, which is not a small number. It's pretty big to find these numbers. If you think that 3% of the population actually that comes to you, 3% or even less will have colorectal cancer. So recruitment of patients is not an easy task. And 104 advanced adenomas. So this is our population where we will discover the biomarkers, and these are proposed to be validated in the prospective study, where we will test the patients if they have these biomarkers that we have found in the first stage, if they have them present, and correlate the findings of their blood with the findings of colonoscopy to see actually if our biomarkers work. As you can see, this is a very interdisciplinary research project between engineering, computer science, and biological sciences. This is very unique as an experience for me as a doctor to work together with these very intelligent individuals coming from other areas, not doctors. And theoretically, once we do this, we will have this nice structure. The outcomes will come, and hopefully it will lead to a decrease in CRC incidence and mortality. Of course, this must be translated into real life, where real life isn't actually so beautiful as the graphs are. But we see that our project is moving on, and we are very happy and very ambitious to see it, to find the appropriate biomarkers. And with this, I would like to thank you, showing you the pictures, first from my hospital where the work is done, and of our group here in our kickoff meeting in the middle, and down in the left from our last recent meeting in Riga in Latvia. Thank you very much.
Thank you. Thanks a lot, Professor Papanikolaou, for this very insightful presentation. And I'm sure that here you covered a lot of ground that was not necessarily familiar with everyone here in the call. And your point of view is truly valuable as a clinician, and it presents us once again with the challenges that the medical community is facing in addressing colorectal cancer, and hopefully where the DIOPTRA project can make a difference. So thank you very much for your insights.
Thank you.
And finally, for some more technical details and insights related to DIOPTRA, we are going now to have Ioannis Vezakis. Ioannis is an AI machine learning engineer from Tecreando, and he's here today on behalf of Christos Androutsos, who is DIOPTRA's technical coordinator, who couldn't join today. So Ioannis will introduce us to some AI-driven innovations and technological advancements in screening. So whenever you're ready.
Thank you, Jada. Can you see my screen? Yeah, great. Thank you for the introduction, Jada. As Jada said, I'm here in place of Christos Androutsos. Unfortunately, he could not join. He's with University of Ioannina, who are the technical managers of the project. My name is Ioannis Vezakis. I'm with Tecreando. We are also a technical partner in the project. I'm here to present the technological aspect, so the innovation and technology applications of the DIOPTRA project. As you heard from Stavros and Professor Papanikolaou, DIOPTRA adopts an integrated approach that combines liquid biopsy analysis and behavioral data with artificial intelligence to create a more accessible screening. So unlike traditional screening methods like colonoscopy or FIT, which we heard about before, which face low participation rates, we're developing a system that integrates with routine blood tests, making screening hopefully more accessible and more convenient. So in a nutshell, let me walk you through the key components of our project. At the foundation is the homogenized colorectal cancer CRC dataset, which combines data from 9 clinical sites across Europe. So that's 8 countries, as we said before. That means we have different healthcare systems and different populations in the project. We collect 2 different types of data. First is the liquid biopsy, so that's blood samples, where we're looking for biomarkers that can assist in the early prediction of colorectal cancer and advanced adenomas through next generation proteomics, transcriptomics, omics in general, and computational analysis. And we couple this data with risk factors. So these are traditional factors like age, family history metrics, but also factors related to lifestyle, which is the diet composition, physical activity patterns, stress, mental state, and checking for correlations between all these and the presence of colorectal cancer. Another part of the project is the mobile application. So we use this to gather data directly from the patients. They can answer questions on this app. They can receive recommendations on this app based on their personalized behavioral score, which we make with the risk assessment module, which we will discuss later on. And finally, what we do is we generate a personalized behavioral risk score of developing CRC. We have two data collection phases. The first is the retrospective data collection, and then we have the prospective, of course. In the retrospective study, we gather medical records, so that's data derived from the electronic health records from multiple clinical sites. That includes demographic, medical and family history information, clinical biology findings, and recorded symptoms. And we also have the biomarker discovery study. Blood is drawn from the patients prior to the colonoscopy, and then there is matched tissue and plasma samples collection. This is important because many studies have identified potential blood-based biomarkers for colorectal cancer. Most of them lack a mechanistic insight into how these markers relate to cancer biology. So in the study, by analyzing both tissue and blood samples from the same patients, we can verify that proteins detected in blood directly correspond to biological processes occurring in the tumor tissue, and also identify biomarkers that are not just statistically correlated with colorectal cancer, but they are also functionally involved in its development. And finally, as I said before, we also have behavioral and personal history data collection through questionnaires. The prospective data is similar. There is blood sample collection again, the colonoscopy and the clinical diagnosis, and the risk factors like sociodemographics, family and personal history, clinical biology, and findings from the colonoscopy. The difference is that we also have a follow-up study here. We ask the participants to download the DIOPTRA mobile application, and in there we have embedded questionnaires where they can answer all these sociodemographics, lifestyle questions, etc. We periodically update this data, so we keep asking them again things like, have you eaten red meat the past week, or how much have you exercised in the previous week? So these kind of updates. And then 1 year after their initial enrollment, there is the follow-up period where again blood is drawn and it is compared with the previous findings, and also we take into account the changes in their behavior and see if there's any correlations there with changes in the blood plasma, in the proteins in the blood. This is the colorectal cancer ontology which we had to develop for the project. As we said before, there's 9 clinical sites, 8 different countries, so different healthcare systems, different kinds of data coming into the project, and we need a homogenized way to represent this, to store this, and ultimately run AI algorithms on them. So what we had to do was take the reference data model, this is the RDM, and transform it into an ontology. And we created the DIOPTRA colorectal cancer ontology here. I'm not sure if you can see the image well, but basically here we represent the individual, and all the data that I mentioned before, the sociodemographics, behavioral, clinical biology, diagnosis, etc., they are all encoded in the common schema, and in this way we have an homogenized CRC database. Regarding the components, this is the DIOPTRA pyramid. These are the main components that comprise the project. We will see a dedicated slide for each of them later on. The first is the DIOPTRA software, which is the interface for structured retrospective and prospective data upload and overall management by the clinicians. The multiplex biomarker assay, which is developed by via the biomarker discovery process, and it is used to extract selected protein features. These are the liquid biopsy biomarkers we mentioned before. The risk factor analysis, which is the AI model identifying and ranking risk factors. The screening AI model, this is a hybrid. It takes the protein features, the risk factors, and combines them into a single prediction to predict the overall probability that the participant has either colorectal cancer or advanced adenomas. Then there is the mobile application, which proposes personalized behavioral interventions based on the user's profile. The risk assessment module, which calculates a personalized behavioral risk score for each user and triggers recommendations. And finally, the mobile app dashboard, where clinicians can go and review the data that we have collected for each participant, including the mobile application data. I will skim quickly through the DIOPTRA software. Basically, this is a dashboard that clinicians have access to. And what it does, it provides an overview of the total number of participants, patients, the data availability of all the categories, data quality metrics. It provides an overview of the uploaded data set and also allows the deletion of records. We implement curation controls there to ensure that the data uploaded are high quality and up to the standards that we have defined. So what we do is that we look into the header row structure, field formats, variable value ranges, correlation-based rules, and missing values. And if the file to be uploaded by the clinicians is not up to the standards, it gets rejected or it gets approved. And in this way, we ensure that we only have proper and high quality data on the dashboard. Additionally, this software communicates with the DIOPTRA mobile app. So not only not only the clinicians have to upload data, but the patients themselves can directly upload data from the mobile phones with the use of the mobile app. Now, this slide, it involves the transition from a panel of, the biomarker assay, to be more precise, involves the transition from a panel of novel protein biomarkers to an in vitro diagnostic assay. So first, we identify a set of protein biomarkers through a mechanism-based discovery pipeline that is good at distinguishing between the DIOPTRA participant groups. So multiplex bit-based immunoassays are used. These are what you see on the image in the left. And these are integrated into the clinical settings. This is a bit-based technology. It has color-coded microspheres. Each of these microspheres is conjugated to an antibody specific to one of the target proteins. And these are then analyzed, and they actually provide the features for an AI algorithm that can predict between normal and abnormal findings. Our partner Portavio, who is responsible for the biomarkers, actually also develops these multiplex kits, which you can see here. These are given to the clinical sites, and they can perform the study inside. So it doesn't need; they don't need to ship the blood samples elsewhere. Now, regarding the risk factor analysis, many studies have investigated the association of colorectal cancer with demographic, behavioral, environmental risk factors. As you probably already know, you also heard it in the previous presentation, the main factor is age. So guidelines suggest screening after 50 years old until around 75. What is seen in clinical practice, however, is that these thresholds are gradually decreasing, something that's currently under investigation as to why. So we need alternatives beyond these age-only recommendations. Symptoms, family history, radiation treatments, these are all factors that are important, but a person has no control over. But there are also factors that they do have control over. And for example, this is being overweight, physical activity, dietary habits, smoking. So we take all these risk factors. We apply this risk factor analysis using various methodologies like statistical analysis, principal component analysis, AI-based techniques. When we use machine learning, we couple this with the calculation of supply additive explanation values. These allow us to interpret the results and again find the most influential factors. And this risk factor set is further evaluated in a subsequent analytic step. And actually, the risk factors that we do have control over are also analyzed further through the risk risk assessment module, which we will see in a bit. So under the DIOPTRA architecture, AI is exploited in the context of three things. The first is the blood biomarker analysis for identifying a discriminative subset of proteins that can successfully predict colorectal cancer. The second is assessing an extended risk factor pool compared to the current limited clinical consideration. And the third is the actual clinical decision support system for stratifying high-risk cases, individuals who are at high risk for having colorectal cancer. And as mentioned before, we also have the mobile application. For us, for the project, the mobile application is there to basically to mostly collect data. So we have the questionnaires. The users have to answer questions like how much red meat did you eat, how much did you exercise, do you have any family history of colorectal cancer, or are you taking any specific medication? However, we also keep asking them questions related to risk factors that they do have control over. For example, did you eat red meat or did you exercise? And this is the way we collect data for the follow-up study. This is the value it has for us. Now, it also has to have value for the user, otherwise they're not going to use the mobile app. And for this reason, we have the health literacy module, which is a central hub where the user can find curated and up-to-date material on colorectal cancer. They know they can trust these articles because they are approved by their doctor. And it aims to promote risk awareness and justify needed behavioral changes to the user. And moreover, it has the risk assessment module and the personalized intervention module. The first one takes into account their behavioral profile through all the answers that they have provided. And the second one, the intervention, it makes recommendations to them so that they can improve their lifestyles and hopefully lead better, more healthy lives. The way we decide what recommendations we're going to show to the users is made through the risk assessment module. And this module uses unsupervised learning, so it clusters participants into several different groups based on the behavioral profiles, based on the answers that they have given to the questionnaires. Then these clusters are manually examined by the clinicians in the project, and personalized recommendations are developed for each of these clusters. There is the logic behind this is the following. We find what kind of questions are the most influential, what is the most likely to make a user change their cluster, and we ask them these questions again. If the most influential question is, I don't know, their dietary habits. We keep asking them questions about their dietary habits, and we're trying to see if they changed anything. And similarly, we also make the corresponding suggestions it better, it more helpfully. To give a simple example. So the risk assessment, I think pretty much I covered this already. The personalized intervention model is designed to map the responses collected through the behavioral questionnaire to evidence-based and personalized recommendations. We make predefined cluster-specific recommendations tailored to the participant's behavioral profile. And these recommendations are displayed to the end user via the mobile application. A few examples of how the mobile application looks. On the left, you can see examples of recommendations. They're regarding physical activity, diet, lifestyle, in this case, smoking. And on the right, you can see an example of how the health literacy module looks. So they can see articles, but also infographics, videos, etc. So to conclude, the technical vision of the DIOPTRA. First, a central repository. This is the establishment of a centralized repository that offers a standardized and easily accessible dataset for advanced CRC research, prevention, and early diagnosis efforts. There is also the potential for alignment with the European health data space that will be explored to further enhance data sharing and collaboration across Europe. Second, predictive tools. To develop non-invasive AI-driven biomarker discovery tools that identify early warning signs of colorectal cancer, advancing the field of personalized medicine. And as mentioned before, these tools are aimed to be in vitro diagnostic tools, so they can be aligned with in vitro diagnostic regulations. AI-driven techniques to predict colorectal cancer risk more accurately, offer tailored health recommendations and behavioral interventions to prevent disease progression and improve patient outcomes. And finally, prevention, which is the contribution to national and global colorectal cancer prevention efforts by identifying key trends and risk factors across diverse populations. Thank you.
So thank you, Ioannis, for this presentation involving AI, the DIOPTRA studies, the app. I think this provides a good overview of the work that you're involved with and how everything is connected. So thank you also for speaking on behalf of Christos. So we don't seem to have questions at the moment, but I just want to remind the audience that you can reach out to us in multiple ways. In the chat, you will find our social media handles, and we're also very active on our websites. So definitely stay tuned there to hear more developments within our projects. So with this, our webinar has come to a close. So I'd like to first thank all of the speakers involved for your time and your presentations. As said earlier, this webinar will be recorded and participants will receive the link in due time. Finally, another reminder, although this was said at the beginning of the webinar, March is Colorectal Cancer Awareness Month. So let's all raise awareness about this disease and encourage synergies among different realms, because as we are seeing today, diversity really brings added value. And so we can also contribute to advancing treatments. So let's connect. And yes, so if there are no more questions or considerations, we will now close this webinar, and I wish you all a very good day.